Hello, everybody. I am Hazal Kutlucan. I'm an obstetrics and gynecology specialist in Gaziantep, Turkey. And I work there as specialist and consultant. And now I would like to share you a case report which I have experienced in our clinic with the review of the literature. And firstly, let's start with the neural tube defects. What are they? Actually, we can say that it is the second structural abnormalities after fetal cardiac defects in fetus. And it is caused by the failures in the closure of the neural arc. And it affects a brain, spine, and also spinal column. And it can be mortal, and around 10% of infants' mortalities are due to these central nervous system defects, and affecting 300,000 births each year. And it's a very actually a big number for actually mortality and also morbidity. And yes, it's about the actually the nervous system. It starts with brain and also with spine and spinal column. It affects the neural tissues and also fat tissues and muscles, all the anatomies. Now we can see the types of neural tube defects, and I will talk about the craniorachischisis. And in another terminology, Craniorachischisis totalis, actually, it's a Greek terminology. Rachischisis actually means that the defect of the nervous system, the effect of the actually the fusion. And if it starts with cranium, we call it as craniorachischisis. And it's the most serious form, I can say it. And the other forms, anencephaly, encephalocele, iniencephaly, and spina bifida, meningocele, and myelomeningocele, we see more oftenly. Yes, now again, we can see the type of the neural tube defects. Actually, it depends on the term of the pregnancy. If it begins in the first neurulation defects, and if it begins in the third neurulation defects, the appearances and the pathologies of abnormalities change. And if it is, it can be open and closed. Open one is more common. And in this type, we can see neural tissue and its elements with the defect of skin. And like we can see in the actual picture, there is it. Yes, here. We can see an open defect here, and we can see the neural tissue and its elements from the skin, actually. But in the closed one, we can see the skin is preserved, and but it is less common. Yes, and the incidence is actually different in the world. We have some data according to the research, and in this data, actually, it is almost 1 in 1,000, I can say it, but it is more than in Ireland and Wales region. And also in Turkey, it is almost 3 for 1,000 delivery, we can say it. But it depends. There are some factors affecting it. The nutritional status is very important. And the maternal diseases like diabetes and obesity. And usage of folic acid supplementation is very important. I will emphasize in the next slide. And food fortification programs. Some countries use these programs for preventing folic acid deficiency. And some environmental toxicants. And there are some genes. There are some also research about the genes affecting this abnormality. And if the woman has one previous history of neural defect, it means that 1/33 recurrence risk. It means, and if the woman has 3 previous history, the risk is increasing, and we can say that 1/10 recurrence risk there is. And also there are some research including the siblings. And if if the woman has a female offspring of sisters, the risk is very high compared to male offspring of brothers. So genetic factors are important also. And like I said in the first part, there are almost 300,000 deliveries with neural defects. And there are accidents, and it's a very important number also, 8.6 million disability adjusted life years for babies. And it can be related on aneuploidy, we can say it, and also it can be an isolated case also, but it can be also related on aneuploidy. Yes, there are some foods which we can add folic acid, like some cereal, breads, and rices, flours. We can add folic acid, and there are such kind of programs of some countries to reduce these deficiencies. Yes, in low-income countries, it's responsible for 29% of neonatal deaths. And also with periconceptional folic acid recurrence risk is decreasing. We can say it's 3 or 5%. And with folic acid supplements, the recurrence risk is significantly decreasing. And also, if we look at the types of neural defects, we can see that the spina for live livers actually, spina bifida is high compared to others. And again, we can see this, and we will discuss this abnormality of both spina bifida and anencephaly. We call it craniorachischisis. It is there isn't any livers in the actual these research. There isn't any livers, and it's a very serious form. And also in another research, they search about the gender of neural defects and if there is a relation between them. And they found that anencephaly is more common in male fetus, while both anencephaly and spina bifida is more common in female fetus, like our cases. But the number of actually study is not so high, and that's why that just we can comment about a small number of study population. And for etiology, if you look at the folic acid and vitamin B12 deficiency is very important, and they also affect the mechanisms of vitamins affect actually each other also. And maternal diabetes is very important, and alcohol consumption, radiation, some anticonvulsants or opioids treatments, some diabetic drugs, and some other medications. And maternal hyperthermia is very important also during pregnancy and period of pregnancy actually. And rubella infection is a very important risk factor. But in actually 95% of women, there is not any risk factor. Just we know the small amount of risk factor for now. And for screening, we use ultrasound and maternal serum alpha-fetoproteinase enzyme. And for diagnosis, again, ultrasound is an important tool for us. And also we use MRI. And alpha-fetoprotein or acetylcholinesterase enzymes are very important for us because of the for fetus the protein is the highest protein for fetus, and if there is an abnormality in the skin of fetus, we can see the enzyme in the maternal blood sample. And we can say that we can measure in between 15 and 20 weeks, and 2.5 is an actually cutoff value for us. And in this cutoff value, we can see anencephaly almost 19 or 100%, and also often spina bifida is very sensitive. But the woman if the woman has insulin-dependent diabetes or obesity and ethnicity, we can see actually more often this abnormality, and we can see the higher values. And if the woman has multiple pregnancies, again, it can be high. And also, it can be normal in closed spina bifida because of the skin integrity. That's why that we should be aware of it. And in this case, actually, ultrasound can be more sensitive for us. It is very important for us. We use maternal serum, alpha-fetoprotein, and ultrasound together. And ultrasound is very sensitive in this aspect. It is for anencephaly it is 90%, for encephalus it is 80%, and also for sick. Actually, maybe in first trimester we can not see very well, but in the second trimester it is very sensitive for diagnosis. And what are we seeing actually in the ultrasound? We see for anencephaly, firstly, we can begin. We see frog-like eyes. It's a terminological actual explanation. And in ultrasound, we see a triangle face, an invisible ossificated cranium like here. And also in third trimester ultrasound, we see polyhydramnios, and we can suspect anencephaly if we couldn't actually see in the previous trimesters. And for spina bifida, there is an important actually findings like lemon sign and banana sign. And what are they? Actually, it's lemon sign is because of notching of the frontal bones, and banana sign is an abnormality of cerebellum. And also we can see ventricular megaly. And here we can see the banana sign of cerebellum, like here, and the lemon sign of cranium because of the notching of frontal bones. Actually, there we can on the mass of actually the sacral mass because of the spina bifida also. Because of the pressure of here, there are some changes in the cranium appearances with ultrasound. Like here we can see it's a normal appearance of cerebellum here, and because of spina bifida it looks like this, and we call it as banana sign. And what is Craniorachischisis totalis? Actually, we saw the pathway coming this pathology, and here we can see that there is an anencephaly in these cases. And also, there is a spinal disorders actually almost until Sakura, we can say it, and we call it as a Craniorachischisis totalis. And it's a study, also another study about muscles. Craniorachischisis looks like this, and it's very actually very long fusion defect, we can say it. There are some research, but they're all like case reports. I made a literature review, but I couldn't see a very big actual research because of it. But it's a very rare, and in Texas, Mexico, they say that like this incidence is very low, and there is, of course, some hypotheses what are the reasons, but they are almost same with neurotype defects. There are some genes suspected, and also there are some again case reports. They say that they saw the pathology with pathology of Cantrell or some aneuploidies like trisomy 18, and also they saw some findings like omphalocele, congenital diaphragmatic hernia, or sternomelia or the prosopus. They saw some other abnormalities with craniorachischisis. What are our case? Actually, the woman was 25 years old, and she doesn't have any alive baby. She has poor abortus history, and she has diagnosed as anencephaly in her second trimester ultrasound. In that time, actually, the termination of pregnancy recommended to her, but she denied. And the patient came to me with total cervical effacement and dilatation, and with active contractions. According to anamnesis, the actual pregnancy was 26 weeks. And the patient said that there is not any folic acid supplementation during the pregnancy. And again, according to anamnesis, there is not any risk factor. And actually, she came and the membrane was ruptured spontaneously. And just actually, I could check the fetal heartbeat, and it was visible parentally. And then actually, she delivered. And with actually, the baby was alive when the delivery has happened. And we gave 2 and 2 Abdulkadir scores. And the fetus was female. Yes, it is our cases. There is not any brain tissue. The brain tissue we can see. There is not a cranium, and there is a fusion defect coming here, like this, here and here. We can say it's actually we can say that the diagnosis after delivery. Previous delivery, just she has known that there is an abnormality about cranium. She supposed that it was an anencephaly, but after that we diagnosed as Craniorachischisis totalis. And yes, the cranial vault was absent, the brain was not fully formed, and the orbit was like bulging eyes, and there was a complete failure, including brain and spine. And neck was shortened and retroflexed, and also, but it's not a total retroflex. In this case, maybe we can say that iniencephaly, but it's not like the retroflexed appearance totally, like we diagnosed anencephaly. So we diagnosed as anencephaly, and the fetal heartbeat was under 60, and the abdomen looks like a ridge. And we can palpate liver, and the newborn reflexes are also absent. And after 10 minutes, actually, we accepted as exitus. Yes, the woman doesn't actually use any folic acid supplement, and why it is very important. Now, I would like to tell about it briefly, because it directly actually increases cell proliferation, and also. The data shows us it decreases the neural defect incidence also, and also the recurrence risk is decreasing. And also, actually, we recommend the patient folic acids together with B12 vitamin because of this mechanism. Actually, in this mechanism, we know that they affect the mechanism together, and we recommend the supplements together also. We know that in spite of evidence-based benefits, still almost half of women don't use this supplement, and because of that reason, consultation before conception is very important. Telling the mother the importance of the supplement is very important, and we recommend 400 microgram a day for all women. But if the woman has a previous neurotip defect fetus history, we should recommend with high dose supplement. And supplementation should start at least 1 month before, and also it should go on after conception. And it affects, of course, neurotip defect abnormalities, neurotip defects, and also it affects cardiac or facial collapse other than neurotip defects. That's why that we should recommend for multiple anomalies also. And if the woman has any history about seizure, and if the woman use anti-seizure medications, or if the woman is obese or diabetes, we should recommend higher doses. As conclusion, a parental diagnosis of neurotip defects enables the option of pregnancy termination. But if the woman doesn't accept it, timing of delivery and the route of delivery is important, and we can manage the delivery as knowing before the delivery, the pathology, And neurotype defect screening should be recommended to all pregnants, actually, because of there is a lack of treatments, and that's why that diagnosing and recommending determination is very important. And increased periconceptional folic acid use and counseling for women with certain medical illnesses at higher risk for neurotype defects, and early maternal screening for genetic factors are possible approaches to reduce in neurotype defects in the population. Thank you for attention.